Welcome back to the deep dive. Today we're really stripping everything down. We're
Yeah.
getting rid of the baggage, the accessories, the complex machinery. We are going completely minimal.
Truly minimal. I mean, in the biological sense, we're approaching the absolute lower limit of what can even be considered a virus.
Yeah, we're talking about parvoviruses today. And honestly, the name gives it away immediately, doesn't it? Parvo comes from the Latin word parvum, which literally just means small.
Truth in advertising.
Yes.
But don't let the name fool you. In microbiology, small definitely doesn't mean weak. It often means efficient, resistant, and surprisingly difficult to manage.
And that is the exact theme we're going to explore today. For you listening, we're using our standard medical microbiology framework. So we are specifically diving into Chapter 45, Murray's Medical Microbiology. That's our primary structural spine today.
Right.
And our mission is to understand how the absolute smallest DNA virus creates this massive spectrum of disease. I mean, it ranges from a totally harmless rash on a kid's cheek to a literal life-threatening crisis in a fetus or a sickle cell patient.
And to help make sense of that, we'll also be layering in some biochemical details from Jauzet's, specifically Chapter 31, because Jauzet's has some fantastic details regarding the receptor biology, which really explains the why behind who gets sick and who doesn't.
Perfect. I want to start with a mental image for you guys. When we talked about pox viruses in a previous deep dive, we described them as these massive brick-shaped viruses that carry their own suitcases full of enzymes.
Yeah, they bring their own polymerase, their own transcription factors.
Yeah.
They are like a fully self-sufficient army unit.
Exactly. But parvovirus is the complete opposite of that. It shows up with absolutely nothing. It has no envelope. It has this tiny, tiny genome. It has zero enzymes. It's like a squatter who breaks into your house and says, hey, I hope you have food, water, and a comfortable bed because I didn't bring any of that.
I'd actually nuance that just a little bit. It's not just a squatter. It is a dependent squatter. And that's really the core conceptual anchor for this entire deep dive today.
Dependent squatter.
Right. Its entire existence is defined by what it lacks. Because it lacks the machinery to replicate itself, it is completely enslaved to the host cell's schedule. It can't just infect any cell at once. It has to find a cell that is already doing the heavy lifting of dividing.
So it's not just lazy, it's fundamentally biologically constrained.
Exactly. It's a minimalist assassin. It travels incredibly light, so it can travel fast. But it needs a highly specific environment to actually pull the trigger.
Let's look at this assassin under the microscope. If we zoom in, way, way in, what are we actually looking at? Murray describes it as 18 to 26 nanometers.
Which is incredibly small. I mean, just to give you a sense of scale, right? A standard red blood cell is about 7,000 nanometers wide. A parvovirus is 20. It is a literal speck of dust on a mountain.
Wow. And structurally, it's described in the text as an icosahedral non-enveloped capsid. Let's unpack that non-enveloped part. In medical school, we usually just call this a naked virus.
Naked is the key word here, absolutely.
Now, intuitively, if I hear the word naked, I think vulnerable. I think of something that's exposed to the elements, something fragile. But in virology, it's actually the exact opposite, isn't it?
It is, and that's a really common misconception.
Huh.
In the viral world, clothing, meaning that lipid envelope, is actually a massive weakness.
Right, because an envelope is just made of fat.
Exactly. It's a stolen piece of the host's cell membrane. And what happens to fat when you expose it to soap or detergent or heat or acid?
It dissolves, it just breaks down.
Right. Enveloped viruses, things like influenza or HIV or SARS-CoV-2, they are actually quite fragile out in the environment. If they dry out, they die. If you use standard hand sanitizer, they die. But a naked virus, like parvo, it consists only of a tightly woven protein shell. It's rigid, it's highly geometric, it's basically wearing armor.
So it's built like a tank.
A microscopic tank. You look at the stability data, and Jabs is really good on this specific point. Parvoviruses are terrifyingly stable. They can survive heating at 56 degrees Celsius for an entire hour.
That's practically boiling.
It's extremely hot. And they can survive in pH ranges from 3 to 9. They withstand lipid solvents that would dissolve other viruses instantly.
Which has huge clinical implications for how we deal with it. This isn't a virus that requires direct, intimate fluid exchange like HIV or hepatitis B.
No, not at all. This virus sits on doorknobs. It sits on plastic toys in a daycare center. It survives on surfaces in a hospital waiting room for a very long time. You can pick it up from a fomite, an inanimate object, long after the infected person has left the room.
That makes sense.
Yeah, that structural stability is directly linked to its incredibly high transmission rates in schools and families. It's tough to kill.
Okay, so we have this tiny armored tank. Let's crack it open and look at the engine, or I guess the lack of an engine, as we were saying. The genome.
The genome is where Parvovirus B19 gets really, really weird. It is a single-stranded DNA virus, often written as ssDNA.
And we really need to pause on that because it is a major outlier for your exams.
It is the only human DNA virus that is single-stranded. Every other DNA virus you study in this course, herpes, adenovirus, poxvirus, hepadinavirus, they're all double-stranded, or dsDNA. Parvo is the lone wolf.
So why is that a problem for the virus? Or I guess, why is it so unusual?
Well, think about the central dogma. DNA in our cells is double-stranded for a reason. It's stable. It's a backup copy system. Single-stranded DNA is inherently unstable. And more importantly, our cellular machinery isn't designed to just copy a single strand of DNA out of nowhere. It needs a template, and it needs a starting point.
And this leads to that fascinating structural quirk mentioned in the structure and replication box in Murray, the hairpin loops. The ends of the genome are described as folding back on themselves. It sounds almost like molecular origami.
It is exactly molecular origami.
Yeah.
And to understand why it does this, you have to go back to that dependent squatter mental model. The virus does not carry a DNA polymerase. It has to use the host's polymerase.
Okay, so it has to hijack our own copying machines.
Yes. But the host's DNA polymerase is a bit like a train. It cannot just drop onto a plain, flat track and start moving. It needs a station. It needs a primer, which is usually a little chunk of existing double-stranded structure to latch onto before it can start laying down new track.
And Parvo doesn't have a primus enzyme to build that starting station.
Correct. It has zero tools. It brings nothing. So it uses a truly genius workaround. The very ends of its single-stranded genome contain what we call palindromic sequences.
Meaning they read the same forward and backward, like the word race car?
Yeah, exactly. The sequence on the strand is complementary to itself. So the end of the DNA strand literally curls around and binds to itself,
Creating a little loop.
creating a double-stranded hairpin at the very end. So when the host polymerase comes floating by, it sees this hairpin, and it thinks, a primer, a double-stranded starting station. It latches on and starts copying the rest of the single strand.
That is incredibly clever. It's like hot wiring a car. You don't have the key, which would be the primus, so you just twist the wires, the DNA ends together, to trick the engine into starting.
That's a really great analogy. It effectively bootstraps its own replication. But even with this trick, it hits a hard biological wall. It has the starting mechanism figured out, but it doesn't have the fuel.
The fuel being the cellular machinery itself, the actual environment of the cell.
Right. DNA polymerase isn't just floating around active in every cell all the time. Our cells have a strict life cycle. G1, which is the first gap phase, S phase, the synthesis phase, G2, and M for mitosis. DNA polymerase is really only active during that S phase when the cell is naturally copying its own DNA to prepare for division.
And since parvovirus has such a tiny genome, I think Murray says it's only about 5.5 kilobases, it just doesn't have the physical space to carry genes that can force a cell to enter the S phase.
Compared to something like HPV, the human papillomavirus, or adenovirus, those viruses have specific, dedicated proteins, like E6 and E7 in HPV or E1A in adenovirus. Those proteins act like a foot on the gas pedal. They actively kick a resting cell into gear and force it to start dividing so the virus can use the machinery.
But parvovirus is too small to carry those genes. It physically doesn't have the luggage space. It only codes for a couple of structural proteins, VP1 and VP2, and a non-structural protein. That's it.
So it is stuck waiting. It can only infect a cell that is already deciding to divide on its own.
The S phase requirement, that's what you called it earlier. And for everyone listening, this is the single most important concept for understanding the pathology we're going to discuss. The virus is completely harmless to a resting cell, like a mature neuron or a skeletal muscle cell. It can enter those cells, maybe, but it can't replicate. It just sits there. It absolutely needs a cell that is a mitotic factory.
It needs a factory.
So, if you are this virus and you land in the human body, where do you go? Where is the biggest factory of rapidly dividing cells in an adult human?
The bone marrow.
The erythroid lineage.
Precisely. The bone marrow is an assembly line that never ever stops. We produce roughly 2 million red blood cells every single second of our lives. To achieve that insane volume, the precursor cells, specifically the burst-forming unit erythroid and the colony-forming unit erythroid, the BFUE and CFUE, they're in a constant rapid state of cycling. They're almost always in S phase.
It's an endless all-you-can-eat buffet for parvovirus.
It is the perfect environment. And there's always it's not enough to just be near the factory. You have to be able to open the front door.
Which brings us to the receptor. This is a detail we're pulling from Jaywitz that really helps explain some of the genetic immunity we see in certain populations. What is the key to the door for Parvovirus B19?
The receptor is the blood group P antigen, also known biochemically as globoside.
Blood group P antigen. I feel like in medical school we learn about A, B, O, and Rh factor, and then we just completely forget the rest of the alphabet.
We do, yeah. P is considered a minor blood group antigen, but for parvovirus, it's everything. This antigen is expressed at very high levels on mature red blood cells and, crucially, on those rapidly dividing erythroid progenitors in the marrow. The viral capsid, that naked icosahedral protein shell we talked about, is perfectly shaped to bind specifically to the P antigen.
And Jaywitz mentions there's a coreceptor involved too, right?
Yes, the alpha-5 beta-1 integrin. The virus needs both, but the P antigen is the primary binding determinant. It's the mandatory first step.
Now here's a fascinating sidebar for you guys. What happens if a patient simply doesn't have the P antigen?
It's rare, but it happens. It's roughly 1 in 200,000 people. They have a genetic mutation where they are P antigen negative, and because of that, they are completely naturally immune to Parvovirus B19. You could inject the virus straight into their bloodstream and absolutely nothing would happen. The virus just bounces off their cells because there's no doorknob to turn.
That's incredible. It's like a genetic lottery ticket. But for the vast majority of us who do have the P antigen, the virus gets in. It finds this perfect erythroid precursor cell that's actively in S phase. It hotwires the polymerase with its little hairpin loop. It replicates its DNA. And then what? What does it do to the cell?
Then it gets violent. Parvovirus B19 is a cytolytic virus. It doesn't bud gently out of the cell membrane like some enveloped viruses do, trying to keep the host alive. It replicates until the nucleus is absolutely packed with newly assembled viral particles, and then the cell lyses. It just blows up.
So it straight up kills the host cell.
It obliterates it. Now, remember what specific cell we're talking about here. We're talking about the precursor to the red blood cell. If you blow up the precursor, you don't get the mature red blood cell.
You stop the assembly line.
You completely halt production at the source. So the fundamental biological event of a parvovirus infection, the root cause of everything we're about to discuss, is a temporary cessation of red blood cell production.
Temporary cessation. That sounds, manageable. But as we move into part 3 here, the pathogenesis, we're going to see that this interruption plays out very, very differently depending on the timeline. Murray clearly describes the disease course as biphasic.
Biphasic is the clinical keyword you need to anchor on for exams. 2 distinct phases, 2 totally different sets of symptoms, and 2 completely different underlying mechanisms.
Let's walk through that timeline step by step. So, say I inhale the virus from a contaminated doorknob. It gets into my respiratory tract, then into my blood. What happens first?
That initiates phase 1. We call this the lytic phase, or the viremic phase. This occurs roughly 7 to 10 days post-exposure. The virus has found its way to your bone marrow. It is actively destroying those erythroid cells, and millions of new viral particles are spilling back into your bloodstream. You have very high-grade viremia.
Okay, so a ton of virus in the blood. What does the patient actually feel like during this phase?
Like garbage, but very non-specific garbage. They have a fever, malaise, chills, muscle aches.
It just feels like the flu.
Exactly. It feels like a bad cold or a mild flu. There are no defining features to tell a doctor, oh, this is parvovirus.
And clinically, if we were to draw their blood, which we probably wouldn't for a mild flu, but if we did, what would we see happening to their blood counts?
You would see reticulocytopenia. Reticulocytes are the immature baby red blood cells that usually float around in the peripheral blood in small numbers. Because the bone marrow factory is currently shut down, there are no babies being produced. The reticulocyte count literally drops to 0.
And is the patient infectious right now during this flu-like phase 1?
Highly, highly infectious. This is the main danger zone. They are shedding massive amounts of virus in their respiratory secretions. They're coughing, sneezing, wiping their nose, and touching every surface around them, but they just think they have a winter cold.
And there's no rash yet?
No rash at all.
Okay, so a week passes, the fever breaks, the patient starts feeling better.
The viremia clears. And why does it clear? Because the host immune system has finally woken up to the threat. The body starts producing IgM antibodies specifically targeted against the virus. These antibodies coat the viral particles, neutralize them, and clear them from the bloodstream.
So the virus is essentially gone, but then phase 2 starts.
Right. Phase 2 is the immunologic phase. This happens roughly 2 weeks to maybe 18 days after the initial infection, so there's a gap. The patient felt better, but suddenly they develop a bright red rash or severe joint pain.
Wait, if the immune system cleared the virus, why are they getting new symptoms now?
That is the great paradox of this disease. The symptoms in phase 2 are not caused by the virus doing damage. They're caused by your own body's response to the virus, specifically a process called immune complex deposition.
Break that down for us. What is an immune complex?
So you have these newly minted antibodies, right? First IgM and eventually IgG. They are binding to all the leftover viral proteins floating around. When multiple antibodies bind to multiple viral pieces, they form these large, sticky clumps. Those clumps are immune complexes. These complexes circulate in the bloodstream, but because they're large and sticky, they get physically stuck in really tight spaces. They get lodged in the tiny capillaries of the skin. They get trapped in the synovial tissue of the joints.
And wherever they get stuck, they trigger an alarm. They cause localized inflammation.
Exactly. They activate the complement system, which brings in neutrophils, which release inflammatory cytokines. The inflammation in the skin capillaries creates the rash. The inflammation in the joints creates the arthritis. It's essentially a type 3 hypersensitivity reaction.
This leads to arguably the most important infection control pearl in this entire chapter. I really want to highlight this for everyone listening because it comes up in real clinical practice constantly. Let's say a child comes to school. They have bright red cheeks, the classic slap cheek rash. The teacher panics and calls the parents, "Come get him, he's contagious."
And the teacher, while well-meaning, is scientifically wrong. By the time that rash appears, the viremia is already gone. The antibodies have already done their job of clearing the live virus. The rash is just the immunological smoke left over after the fire has already been put out. The child is no longer infectious.
But the terrible irony is that the kid was probably spreading the virus to the entire classroom a week ago when he just had a runny nose.
Exactly. It's a hit-and-run pathogen. By the time you can visually identify the suspect via the rash, he has already fled the scene.
That's a great way to remember it. The hit is phase 1, the echo is phase 2. So we've established the basic mechanism. The virus kills the marrow precursors in phase 1, and then immune complexes cause inflammation in phase 2. Now let's move into part 4, clinical syndromes, because this is where the exam questions really live.
The overarching theme here is context is king.
I love that phrase, because the virus is doing the exact same mechanical thing in every single patient. It's a simple, minimalist machine. It only knows how to do one thing: infect S-phase erythroid cells and isolate them. But the patient's baseline physiological background changes the clinical outcome entirely.
Right. It's the same trigger, but a different target board. Let's look at scenario A first. The healthy, immunocompetent child. This is the classic presentation we all think of.
This is fifth disease. Can we just briefly talk about why it's called that? It sounds like a bad movie sequel.
It's a quirky relic of medical history, actually. In the late 19th and early 20th centuries, pediatricians were trying to systematically categorize the classic childhood examptoms, the rash-causing diseases. So first disease was measles, second disease was scarlet fever, third disease was rubella, fourth disease was, well, something called Duke's disease, which we don't really recognize as a distinct entity anymore. And fifth disease was Erythema infectiosum, which we now know is caused by Parvovirus B19.
So it's literally just the fifth bullet point on an old medical list.
It is. And in children, it presents with that incredibly classic slap cheek appearance.
Describe what that actually looks like for someone who hasn't seen it.
It's a very intense, bright, confluent erythema right on the cheeks. It genuinely looks like the child was slapped with an open hand. Interestingly, it typically spares the area right around the mouth. We call that circumoral pallor, and it spares the bridge of the nose.
And then it spreads, right?
Yes. Usually 1 to 4 days after the facial rash appears, a secondary rash erupts on the trunk and the limbs. This one is very distinctive. Murray describes it as maculopapular, but the high-yield descriptive word you want to look for is reticular, or lacy. It looks like a pink, delicate net pattern drawn on the skin.
And this rash kind of comes and goes.
It does. It waxes and wanes. Things that increase blood flow to the skin, like sunlight, hot weather, exercise, or taking a hot bath, can cause the rash to flare up again, sometimes for weeks after the initial infection. But generally speaking, in a healthy child, this is a completely benign, self-limiting illness. No treatment is needed at all.
Now let's switch contexts. Scenario B, the healthy adult. Does an adult get the slap cheek rash?
Usually no. Adults, and particularly adult women, have a very different immune response pattern to this virus. They're much more prone to the joint symptoms rather than the skin
Oh,
symptoms.
arthropathy.
Yes, specifically a polyarthritis, which means inflammation involving multiple joints simultaneously. It typically affects the small joints of the hands, the wrists, the ankles, and sometimes the knees. And it is notably symmetrical, both hands, both wrists.
Now, symmetrical small joint pain in the hands of an adult woman. That sounds incredibly suspiciously like rheumatoid arthritis.
It mimics RA perfectly, and that is a huge, huge diagnostic trap in primary care. I've seen patients who were referred to rheumatology for suspected new-onset rheumatoid arthritis. They are stressed out of their minds only for the labs to come back and show they just had a parvovirus infection a few weeks prior.
So how do you tell the difference clinically, besides waiting for serology?
Time is the ultimate differentiator. Rheumatoid arthritis is chronic, progressive, and destructive. It erodes the bone. Parvovirus arthropathy is completely self-limiting. It might take weeks, sometimes even a few months, for the immune complexes to fully clear out, but it will go away, and it leaves absolutely zero permanent joint damage.
Okay, so for healthy kids and healthy adults, it's annoying, maybe painful, but ultimately benign. Now let's raise the stakes. Scenario C, the patient with a stressed marrow.
This is where the simple biology of the virus becomes incredibly dangerous. We're talking about patients with underlying chronic haemolytic anemias, sickle cell disease, thalassemia, hereditary spherocytosis.
What defines these patients physiologically that makes them so vulnerable?
It's all about the lifespan of their red blood cells. A normal, healthy red blood cell lives for about 120 days. But in a patient with sickle cell disease, their red blood cells are fragile and abnormally shaped. They might only live for 10 to 20 days before they are destroyed by the spleen.
So their bone marrow must be working overtime constantly just to keep up.
It's sprinting. It is running a marathon at a dead sprint just to maintain a baseline, barely adequate hemoglobin level.
Yeah.
They have absolutely no reserve capacity. They're essentially living paycheck to paycheck with their red blood cells.
So what happens when parvovirus enters that specific environment and shuts down the factory for 7 to 10 days?
They go completely bankrupt. Let's do the math. In a healthy person, if you stop making new red blood cells for a week, your hemoglobin might drop from, say, 14 to 13. You wouldn't even notice.
Yeah.
But in a sickle cell patient, because their existing cells are dying off so incredibly fast, if you halt the replacement line for a week, their hemoglobin crashes from an already low baseline of maybe 8 down to a critical 3 or 4.
Wow. That's a level that is incompatible with life.
It is an absolute medical emergency. They present to the ER with severe pallor, extreme tachycardia, because the heart is trying to pump whatever oxygen is left, profound fatigue, and shortness of breath. This specific clinical event is called a transient aplastic crisis, or TAC.
Transient because the bone marrow will eventually recover once the immune system clears the virus.
Right, but it's a crisis because they will literally die of heart failure and hypoxia before they recover if you don't intervene and give them a blood transfusion.
And crucially, unlike the kids who present with the rash in phase 2, these aplastic crisis patients are in phase 1, right?
That is a critical infection control point, yes. They are presenting during the factory shutdown phase, which is the viremic phase. So they have astronomically high viral loads in their blood and respiratory secretions. A patient in an aplastic crisis is incredibly infectious. You absolutely do not put them in a shared hospital room with a pregnant nurse or an immunocompromised patient. They need isolation.
Which brings us directly to scenario D, arguably the most tragic context, the fetus.
This is Hydrops fetalis.
Let's break down the physiology here. Why is the fetus so uniquely vulnerable to this virus?
It's actually very similar to the sickle cell patient in terms of hemodynamics. The developing fetus has a massive constant demand for new red blood cells because it is growing so rapidly. The lifespan of fetal red blood cells is naturally shorter than adult cells. And importantly, during the first and second trimesters, the primary site of red blood cell production isn't the bone marrow yet. It's the fetal liver.
Okay, so the pregnant mother inhales the virus, she gets a mild flu, the virus crosses the placenta.
It crosses the placenta, it finds its way to the fetal liver, it targets the actively dividing erythroid precursors there, and it lyses them. The fetus suddenly stops making red blood cells. It develops a profound, severe anemia.
And the consequence of severe anemia in a fetus is heart failure. Can you explain the mechanics of how anemia leads to heart failure?
It's pure fluid dynamics. When you have very few red blood cells, the blood becomes very thin. The viscosity drops. It's like pumping water instead of syrup. Furthermore, that thin blood is carrying very little oxygen to the developing tissues. The fetal heart senses this hypoxia, and tries to compensate. It starts pumping faster and harder, trying to circulate what little oxygen it has more frequently. This constant overdrive leads to high-output cardiac failure.
The heart just exhausts itself and fails.
It fails, and when the heart fails as a forward pump, pressure backs up into the venous system. Fluid starts leaking out of the congested capillaries and into the fetal tissues and third spaces. You get fluid accumulation around the lungs, which is a pleural effusion, fluid in the abdomen, which is ascites, and massive edema in the skin and subcutaneous tissues. When a fetus becomes completely swollen with fluid like this, that is the definition of Hydrops fetalis.
And this frequently leads to fetal death.
It can be fatal, yes.
Yeah.
But I want to make a very, very specific distinction here because this is a classic trap on board exams. Is Parvovirus B19 teratogenic?
Teratogenic meaning it causes structural birth defects, like thalidomide causing limb deformities, or rubella causing congenital cataracts and heart defects.
Exactly. And the answer is no. Parvovirus is absolutely not teratogenic. It does not scramble the developmental blueprint of the baby. It doesn't cause limbs to fail to form. It causes a very specific plumbing and supply problem. It causes anemia.
That makes total sense.
Yeah, if you can keep the baby alive through the anemia, which maternal fetal medicine specialists can sometimes do by performing an intrauterine blood transfusion, literally navigating a needle through the mother's abdomen into the umbilical cord to give the fetus packed red blood cells, the baby can survive. And if they survive the crisis, they are born completely normal. No brain damage, no missing organs.
That is a critical takeaway. Rubella equals developmental defects. Parvo equals severe anemia and heart failure, but normal development if they survive.
Exactly. And the risk of this happening is by far the highest if the maternal infection occurs in the first 20 weeks, the first half of the pregnancy, when the fetal liver is the main site of hematopoiesis.
Finally, we have scenario E, the immunocompromised patient. This could be a kidney transplant patient on anti-rejection meds or a patient with advanced HIV.
The fundamental problem here is a failure of the host immune system. Specifically, they cannot mount an effective humoral response. They can't make the neutralizing IgM and IgG antibodies required to clear the virus from the blood.
So they get stuck in phase 1 forever.
Essentially, yes.
Yeah.
They never clear the viremia. They establish a persistent chronic infection. The virus just sets up shop in the bone marrow and keeps gnawing away at the erythroid precursors day after day, week after week. They develop a chronic, severe, unrelenting anemia that we call pure red cell aplasia.
Because it's only the red cells being affected. The white cells and platelets are totally fine, right?
Exactly. Because the virus specifically targets the P antigen on the erythroid line.
And if you did a bone marrow biopsy on one of these patients, what would you see? There's a very specific buzzword here.
You would look for giant pronormoblasts. These are massive, abnormally large, immature red blood cell precursors. And if you look closely at their nuclei, you will see prominent viral inclusion bodies. It's a pathognomonic finding. If you see giant pronormoblasts in a patient with chronic anemia, you have your diagnosis.
Okay, so we've thoroughly covered the basic biology and the 5 major clinical syndromes. Let's pivot to how we actually figure this out in a real hospital setting. Part 5, diagnosis and treatment.
Diagnosis is really a tale of 2 entirely different tests. You have serology, which looks for antibodies, and you have PCR, which looks for the viral DNA itself. You have to know which one to use when.
Let's run through some scenarios. If I have a healthy adult woman presenting with symmetrical joint pain, or if I have a pregnant teacher who was just exposed to a student with fifth disease, what test do I order?
You order serology. In these immunocompetent patients, you are looking for their immune response to the virus.
So we test for IgM and IgG.
Right. IgM indicates an acute or very recent infection. It means I have it right now or I just fought it off last week. IgG indicates past infection and long-term immunity. It means I had this years ago and I am protected.
So if our pregnant teacher gets her lab results back and she is positive for IgG but negative for IgM, we can celebrate.
We can absolutely celebrate. She's immune. The virus cannot harm her, and more importantly, it cannot reach her baby. She doesn't need to stay home from work.
But what if I have a sickle cell patient crashing in an aplastic crisis, or an AIDS patient with chronic pure red cell aplasia?
In those specific cases, serology will likely fail you, and it might lead you to a deadly misdiagnosis. Think about the timeline. In the aplastic crisis, the patient is squarely in phase 1. Their immune system hasn't had time to manufacture IgM yet. The test will be negative, even though their marrow is full of virus.
And in the AIDS patient?
They might never make antibodies because their immune system is fundamentally broken. So again, the serology will be negative.
So if we can't look for the body's reaction to the intruder, We have to look for the intruder directly.
Correct. You use PCR polymerase chain reaction to amplify and detect the actual viral single-stranded DNA in the patient's blood. Because both the aplastic crisis patient and the immunocompromised patient are highly viremic, the PCR will be glowing positive.
That makes perfect sense. Match the test to the phase of the disease. What about treatment?
It depends entirely on the syndrome. For the healthy kid with fifth disease, nothing. Supportive care, maybe a popsicle. For the adult with arthropathy, NSAIDs like ibuprofen to manage the joint pain and inflammation while the immune complexes clear out.
What about the aplastic crisis?
That requires urgent blood transfusions. You are essentially artificially propping up their hemoglobin to keep their brain and heart oxygenated, buying them time until their own immune system clears the virus and their bone marrow factory restarts.
And what do we do for the immunocompromised patient who literally cannot make the antibodies needed to clear the virus? How do we cure their pure red cell aplasia?
If they can't make their own antibodies, we have to give them someone else's. We use a treatment called IVG, intravenous immunoglobulin.
How does that work?
IV is a pooled blood product made from the plasma of thousands of different healthy blood donors. Because fifth disease is so common in childhood, a huge percentage of those donors naturally have anti-parvovirus IgG circulating in their blood. So when we pool it all together, we create a concentrate of protective antibodies. We infuse that into our immunocompromised patient, and those donor antibodies hunt down and neutralize the virus for them.
That's amazing. It's literally borrowing an immune system. Okay, before we get to our final review quiz, we need to briefly nod to the other parvoviruses. B19 is obviously the superstar of the family, but Murray and Jawetz do mention a couple of others.
Yeah, we should definitely touch on Bocavirus.
Bocavirus. Funny name.
It is. It's named that because it's genetically related to bovine and canine parvoviruses,
Right.
the ones that infect cows and dogs. But human Bocavirus is a respiratory pathogen. We primarily isolate it from the respiratory secretions and stool of young children, usually under the age of 2, who present with acute respiratory tract infections. Lots of wheezing, bronchiolitis, coughing.
Is it considered a major dangerous pathogen?
Its exact clinical significance is still a bit debated in the pediatric world. The issue is that we very frequently find it co-infecting alongside other known heavy hitters like RSV or adenovirus. So it's sometimes hard to tell if the Bocavirus is one actually driving the bus and causing the severe symptoms, or if it's just a passive passenger along for the ride. But it's definitely associated with respiratory illness in infants.
And then we have the good parvovirus, AAV adeno-associated virus.
This one is absolutely fascinating from a bioengineering standpoint. It belongs to the genus Dependovirus. And it takes the concept of the dependent squatter to an extreme level. B19, as we discussed, just needs a cell in S phase. But AAV is so defective, so stripped down and minimalist, that it cannot replicate even in a rapidly dividing cell. It is missing too many pieces. It absolutely requires a helper virus, usually an adenovirus or a herpes virus, to co-infect the exact same cell at the exact same time to provide the missing replication machinery.
It's a squatter that relies on another squatter.
Exactly. It rides the coattails of bigger viruses. But here's the brilliant part. Because AAV causes no known human disease whatsoever, and because its protein capsid is so incredibly stable and efficient at entering human cells, scientists have turned it into a molecular delivery truck. We use AAV as one of our primary viral vectors for gene therapy.
So we literally gut the virus and put in a helpful gene instead.
Yes. We take out the viral DNA and we replace it with a therapeutic human gene. For example, the gene for factor VIII for a patient with hemophilia, or a functional gene for a rare retinal dystrophy. We infect the patient with this bioengineered AAV. The virus does what it does best. It targets a cell, enters the nucleus, but instead of causing lysis, it delivers the cure. It safely deposits the therapeutic gene. It's truly the ultimate redemption arc for the parvovirus family.
That is beautiful. From a minimalist assassin causing a plastic crisis to a minimalist savior curing genetic diseases.
Precisely. It's all about how we leverage the biology.
All right. We have covered a massive amount of ground today, from the hairpin loops of ssDNA down to the fluid dynamics of Hydrops fetalis. Now it's time to test if it actually stuck. We are going to do our clinical rounds. I'm going to present a rapid-fire case scenario. I want you, the listener, to pause, think about the answer, and commit to it. Then our expert will break down the exact reasoning. Ready?
Let's do it.
Case 1. You are a GP working in a clinic. A 30-year-old woman comes in complaining that for the last week she can't button her shirt or hold her coffee cup in the morning. Her hands hurt terribly. Her wrists are swollen and tender on both sides. She's crying because she is terrified she's developed rheumatoid arthritis. On taking her history, she offhandedly mentions that her 6-year-old son had a bright red rash on his face about a month ago. Here is the question. What is the most likely long-term prognosis for her joint pain? Pause.
The answer is complete resolution. This patient is experiencing parvovirus arthropathy, which she caught from her son, who clearly had fifth disease. While her symptoms mimic rheumatoid arthritis perfectly due to the symmetrical small joint involvement, the key differentiator for your exams is the prognosis. Parvovirus immune complexes do not cause erosive bone changes. They do not cause permanent joint deformity. It is entirely self-limiting. You can reassure her that while it might ache for a few more weeks, she will completely recover. Review the clinical syndrome section in Murray for this pattern.
Case 2. You are covering the hematology ward overnight. A 12-year-old patient with known sickle cell disease is admitted in shock. They have extreme fatigue, severe pallor, and a heart rate of 120. Their hemoglobin has crashed to 3.5 grams per deciliter. The lab calls to tell you the reticulocyte count is 0.1%. Question. From an infection control standpoint, is this patient currently infectious? Pause.
The answer is yes, highly infectious. This patient is in a transient aplastic crisis caused by Parvovirus B19. The fundamental mechanism here is active, ongoing viral lysis of the bone marrow erythroid progenitors. Because the virus is actively replicating and destroying cells, this corresponds to phase 1, the viremic phase. Unlike the child with the slap cheek rash who is in the non-infectious phase 2, this sickle cell patient has astronomical loads of live virus in their blood and respiratory secretions. Strict droplet isolation is absolutely mandatory. This distinction is crucial in Murray's pathogenesis section.
Case 3. Let's do a pure basic science question. We are observing a viral structure under an electron microscope. It is completely non-enveloped, and genomic analysis reveals it contains linear, single-stranded DNA. Question. Why must this specific virus infect a host cell that is actively in the S phase of the cell cycle? Pause.
The answer is, it lacks its own DNA polymerase and cannot independently stimulate cell cycle entry. Because it only carries single-stranded DNA and has a microscopic genome, parvovirus brings 0 replication enzymes to the table. It relies entirely on the host DNA polymerase to copy its genome. The host cell only expresses and activates DNA polymerase during the S phase, or synthesis phase. Since the virus is too small to carry proteins that force a resting cell to divide, unlike HPV or adenovirus, it has no choice but to sit and wait for a cell that is already naturally cycling. This is a core concept from JAWS Chapter 31.
Case 4. A pregnant woman at 16 weeks gestation is exposed to a child with confirmed Parvovirus B19. We test her serology, and she is IgM negative and IgG negative, meaning she is not immune and is currently susceptible. She is panicking about her baby developing severe birth defects. Question. What is the actual primary physiological risk to the fetus in this scenario? Pause.
The answer is fetal anemia leading to Hydrops fetalis. You must remember that Parvovirus B19 is not keratogenic. It does not alter embryonic development or cause structural malformations like rubella does. The risk is that the virus will cross the placenta and destroy the rapidly dividing red blood cell precursors in the fetal liver. This causes profound fetal anemia, which forces the developing fetal heart to pump at an extreme high output rate to compensate. This inevitably leads to cardiac failure, widespread fluid accumulation, which is hydrops, and potential fetal death, entirely due to hemodynamic collapse, not developmental defects.
Case 5. Last one. A 55-year-old renal transplant patient who is on heavy daily immunosuppressant medications presents with a persistent worsening anemia over the last 3 months. You suspect a chronic Parvovirus B19 infection. You order Parvovirus IgM and IgG serology panels, but both come back completely negative. Question. What is your necessary next step to confirm the diagnosis? Pause.
The answer is, order a PCR test to detect viral DNA in the blood. In a profoundly immunocompromised host, like a transplant recipient, the humoral immune response is suppressed. They may be physically incapable of manufacturing the IgM or IgG antibodies required to trigger a positive serology test. Therefore, looking for the immune response is useless. You must test for the physical presence of the virus itself using polymerase chain reaction. And if you did a bone marrow biopsy, you'd be looking for those classic giant pronormoblasts.
Perfect. How did you guys do?
If you struggled at all with visualizing the biphasic timeline, figuring out when the virus is high versus when the rash appears, I highly recommend you open up Murray Chapter 45 and study Figure 45.4. It's a fantastic graph that maps out the viremia against the immune response perfectly.
And if you missed the nuances about the P antigen receptor or the incredible environmental stability of the naked capsid, Go read the specific properties section in Jowett's Chapter 31.
Mm.
It's a short section, but it's incredibly high yield for exams.
It really is worth the read. It ties the clinical picture to the biochemistry.
We will leave it there for today. Parvovirus B19, the tiny indestructible tank, the dependent squatter. It is a fascinating virus that fundamentally proves you don't need a massive complex genome to cause massive complex systemic problems. You just need to find the exact right vulnerability in the host's biology.
Minimalist, extremely efficient, and highly dangerous in the right context.
Thanks for listening to The Deep Dive. We'll see you next time.